In Nigeria, a group of critical care professionals are taking their services from one hospital to another. How practical is this model? What is the impact on the high cost of healthcare as more people turn to medical tourism? Also in Kenya, another organization wants citizens to be able to access comprehensive healthcare right in their homes.
Nigerians spend over $1 billion on medical tourism annually. According to the country's Ministry of Health, at the start of the pandemic, only 71 public hospitals were found to have intensive care units, with just 350 ICU beds between them. This translates to one ICU bed to 571,000 Nigerians. In many of these, the mortality rate is high. In November 2017, Pamela gave birth to a second child, Kaima. For the next 6 months, she would go through 5 hospitals looking for solution and the right facilities to save her daughter's life.
She wasn't eating at all. She doesn't cry. We had to see the cardiologist. I kept on going. They kept on looking at me as if why I was complaining. He said that is not a serious issue. We can go back and stop worrying.
By the time Pamela took her daughter to the Lagos University Teaching Hospital, Luth, she was told her daughter's case had become critical.
Then she now had a very serious episode. I realized she just turned pale. Her lips were like dark blue. We rushed her to the hospital and they were able to understand that she had a serious heart condition, but they didn't know what it was. So I kept on going to private hospitals. I felt they were not giving me the response I needed. So I decided that I would probably go to government hospital, but they didn't have bed space. And I could see that some people were admitted on the chairs. And they said, apart from the fact they don't have bed space, they don't have oxygen. And she needs oxygen right now because she wasn't breathing. So I had to, get a car that would take me to Luth Hospital. That's like the 5th hospital I'm going to. As soon as I got to Luth too, they said no oxygen too. I realized that they didn't have the facilities because when they finally got the diagnosis, it took the head pediatric cardiologist more than 3 hours to diagnose. This is the 6th month. She was now 6 months old when they finally found out that she had core triatrial hypoplasty, yes, and accompanied with high blood pressure.
She believes her child did not get a fighting chance due to the lack of proper life-saving and diagnostic equipment in the hospitals she visited.
They said we have to travel out of the country, India to be specific, because Nigeria did not have the facility to carry on with the surgery. We had paid half part of the surgery to the hospital in India and trying to get the flights that would take us, space for her oxygen and everything. She just changed before my eyes. Her mouth was black, her lips were black, her body was shutting down. Everything just went south from that moment. They were trying to resuscitate her.
Stories like that of Pamela is all too common in Nigeria, where public hospitals face lack of funding, lack of personnel, and essential life-saving equipment. Dr. Seyi Oyeshola is a UK-trained ICU specialist whose group of medical practitioners move from hospital to hospital providing intensive care for facilities or patients who need their services.
In Nigeria in particular, it was observed over the years that many patients actually lost their lives, not because they were not good doctors or reasonably good hospitals, but because the facility of critical care was not available. Now, critical care serves the purpose of being a safety net for major organ support in patients who are severely ill. There is the situation that arises every now and then where a patient already knows of our existence and they can call us directly. In that situation, we have no choice but to try and support them. But again, it's important to involve their family physician, involve the doctors who've been looking after them before, so that we at least have a baseline of past medical history to work with. Because of the pandemic, there was a major restriction in the way people could actually leave the country, or for that matter, go anywhere. For that reason, our role became vital. Because anesthesia and critical care consultant was already in the country with sufficiently trained senior consultant anesthetists, we were able to treat and be lifesavers to people who had severe COVID. Good healthcare is expensive. Good critical care is expensive. But the way our model works, it has allowed us to spread the cost across a number of hospitals. We spread the resources we have across a variety of hospitals. And so no particular one hospital, or for that matter, no particular one patient has to bear the full cost of providing these services and receiving them, rather, from our group.
According to medicaltourism.com, the average cost of a heart bypass surgery alone in India is $7,000. Hip replacement surgery can be anywhere between $7,000 and $14,000, while gastric bypass can cost an average of $9,000. But these exclude other costs such as travel, ambulance service, companion costs, hospital stay, post-surgery care, and many others.
Traveling abroad is great if you can afford it, but even if you can, it is not every situation that makes it affordable. For example, you need to have the people who speak your language, you need to have the travel ability, and an air ambulance. It's about $100,000 just to get there. Then you have to take people with you who will support you. And on top of all that, you have to pay in hard currency for a service that you could easily have received here.
Healthcare receives a limited budget across many African countries. In Nigeria, only 4% of this year's $32.84 billion budget is allocated to healthcare. South Africa spends the most on healthcare in sub-Saharan Africa at $17.7 billion in 2021, amounting to 5.58% of its GDP. Kenya's $1 billion budget on health for this year amounts to just a little over 1% of its GDP. In Kenya, another group, Checks Up Medical, is also taking healthcare on the road. For this team, distance should not deter people from accessing basic healthcare.
So we came up with a solution where we wanted to be able to offer services, comprehensive outpatient services in standalone facilities, but then also broaden our reach by actually having a home-based, community-based strategy to actually tap into the communities that we wanted to serve. The COVID-19 pandemic opened a Pandora's box, and in that we actually saw there was a need to be innovative in our approach and change how we do things. Trained clinical professionals as well as non-trained service providers who go into the community and actually screen people for non-communicable diseases. We actually have incorporated mobile services as well in terms of having a hospital on wheels, fully paged, integrated pharmacy, laboratory, EKG, ultrasound, the whole nine, in terms of taking care to the people and making sure that care is comprehensive. Where we have e-consultations, less than 500 shillings, where a person at home can actually consult with a physician and actually have a concierge service where medications are delivered to them. So far, we have reached over 70,000 households, we have touched over 5,000 lives, and we keep on going. We're trying to enable people to actually take on wellness and seek promotion, health promotion activities. In terms of the community-based services we provide, affordability is key. Almost 98% of our population with a mobile phone. It's changing the way healthcare is being provided, access, how we talk to, how we communicate. In terms of diagnosis, our nurses in the communities are able to screen and are able to use WhatsApp, are able to use Android technologies to be able to speak to physicians that are in headquarters, so to speak, take pictures and so on and so forth in terms of gathering the right information so that the physician on the other end can make the right diagnosis.